listening to the Pharmacy Podcast Network.
This is the PGX for Pharmacists podcast. We believe pharmacists are the best positioned providers to lead in PGX. Pharmacogenomics is the study of how genes affect a person's response to drugs. This relatively new field combines pharmacology and genomics to develop effective, safe medications and doses that will be tailored to a person's genetic makeup. This podcast is dedicated to pharmacists with an interest in learning more about the data analytics, industry trends, and evidence-based usage of pharmacogenomics. Welcome to PGX for Pharmacists, part of the Pharmacy Podcast Network.
Hi everyone, my name is Banaz Sarami, your host to PGX for Pharmacists podcast on the largest pharmacy podcast in the nation and one of the top 20 podcasts in genomics globally. If you're new to the podcast, I'm a pharmacogenomics medical science liaison and a mentor to pharmacists. Connect with me on LinkedIn and let's start a conversation going. I want to hear from you and how you're impacting patients, payers, or clinicians and what you've learned through your journey to share with us. Being a PGX advocate requires going beyond a certificate and reading an actionable genetics report. I want to hear from you, so let's connect. PGX for Pharmacists podcast is focused on learning the science behind PGX, since that's where the missing gap is for both providers and pharmacists. And that's the missing gap also, which will push PGX into adoption. We also cover business side of it, along with reimbursement and more. So stay tuned for more episodes. If you have been following our episodes, you will know that we've talked about DPYD testing and had an amazing guest who shared her mother's tragic story with us a while back. It was such an important topic that I wanted to address it again on this podcast. So in case you missed it, you will be learning a lot today. And if you did listen to it, there's still so much more to learn. So let's get into it. DPYD is a gene that provides instructions for making an enzyme called dihydropyrimidine dehydrogenase, or DPD for short. This enzyme plays a very important role in breaking down a substance called uracil, which is found in our DNA and RNA. Any mutation in this gene, the DPYD gene, can lead to a decrease in or absence of DPD activity, which, if you think about it, can cause a buildup of uracil in the body. So if someone is DPD deficient, it can make it difficult for the body to process certain chemotherapy drugs, and it can lead to severe side effects such as nerve damage, GI problems, and even death. So you can start to see the importance of a genetic testing before being placed on a chemo agent to see if there's a DPD deficiency. So according to advocates for Universal DPD DPYD Testing, or AUDT for short, Europe is becoming the standard of care for testing for this gene. And only in some selected institutions in the US, the testing is being done. AUDT is a nonprofit organization that's made up of a group of patient advocates and medical professionals who are seeking to improve treatment outcomes for patients that are preparing to receive chemotherapy based on fluoropyrimidine drugs. We have with us today one of the founders of this nonprofit organization, Merritt. She lost her mom in 2014 due to being DPD deficient, and after getting her first infusion of 5-FU. Karen dedicated herself to advocating and raising awareness about pre-testing for DPD deficiency before fluoropyrimidine chemotherapy administrations to reduce unnecessary suffering. Thanks, Karen, for taking time to come on the show today.
Thank you, Banaz, for having me. It's a pleasure to be able to share about this important topic and educate more people, as patients need to be aware of what's out there.
Yeah.
Especially as we know more and more about the human genome and that we all metabolize medicine differently. Prior to 2014, when my mom passed away, I knew nothing about pharmacogenomics, and I knew nothing that our bodies could have different variants, and that even within a family, the variants aren't all the same or aren't passed on. So my mom began, like you said, she had her first infusion of 5-FU, which is a fluoropyrimidine chemotherapy, and the oral version is capecitabine, also called Xeloda. And she started on June 9th, 2014, and she died on July 2nd. So not very long from her first infusion to when she died. She was set up to have 2 treatments of this with concurrent radiation. My mom had a port put in, so it was a continuous infusion. She had been a nurse, and she knew that she was dehydrated from all the diarrhea and vomiting. She called her oncologist, who said, you need to get some hydration. So she went to the emergency room, which was 5 days after her infusion had started, and got IV fluids, but they didn't really observe her well enough. So emergency rooms don't know how to diagnose this toxicity to 5-FU. They didn't even call her oncologist, and the oncologist did not follow up. So if they'd been educated about 5-FU toxicity, perhaps they would have taken other steps. Now, there is what they call an antidote to 5-FU toxicity called uridine triacetate, or Vistigard. This got FDA approval, but not until the end of 2014. And it's not always administered properly, and it's very expensive. So a lot of hospitals don't keep it on stock. So my mom went home from the ER, and her conditions continued to worsen, and she became weaker. On June 19th, so 9 days after her first infusion was started, she got out of bed and fell and was unable to stand up. So she was taken to the hospital by ambulance. By this time, her mouth was so sore and she could barely swallow or talk. They couldn't even get her to explain how she was feeling in the emergency room. My stepdad needed to do it. At this time, they informed us that this was a much worse reaction to 5-FU than's normal, and that with her level of mucositis, they suspected DPD deficiency. At this time, we were like, what is DPD deficiency? So we Googled it, of course, and found out more than we wanted to know, and wondered, why had we not been told about this before? Why had she not been tested? And the oncologist had told us that it was not possible to suspect this DPD deficiency prior to treatment. This is written in her medical record. With what we know now, we know this not to be the case. She could have been tested beforehand, and she was now past the window of opportunity for Vistigard. The oncologist said that her mucositis would last for several days and she would eventually recover. Well, this was false hope. The damage was already done. By June 25th, she was in a comatose state and unresponsive. Her white blood cell count was 0.1, which basically meant she was not able to fight off any infection. She continued to suffer in the hospital with round-the-clock care, and on July 2nd, 2014, she died. It was a lot of suffering that she went to, and a horrible way to die. Unfortunately, on her death certificate, the number 1 cause of death was listed as cardiac arrest. We should have fought to change that. It should have been an adverse reaction to 5-FU, which was listed as the 4th or 5th reason on her death certificate. We like to remember my mom, Linda, as so easy to live with and so hard to live without.
Well, I'm sorry to hear that. I really am. I know you're not the only person that had to go through this with your mom, or actually, some people, their siblings, family members, things like that. But you bring up a good point about the reason why she died. Is there? I mean, it was very clear by how you described it that everybody realized it was a side effect of that medication. Is there a reason why they decided to put cardiac arrest instead?
Perhaps so the hospital didn't have to report it as an adverse drug event, or just like factually at the end, it was her heart that gave out.
I gotcha. Yeah.
Yeah.
So tell us about the the nonprofit organization that you created and why you did that, and how are you reaching more people, and not just the individuals going through chemotherapy and their caregivers, perhaps, but also, perhaps the clinicians or the oncologists or things like that, which is probably even more important.
Well, yes. So advocates for Universal DPD, DPYD testing. We actually started the nonprofit formally last April. So it's been a year anniversary. When we were in the hospital with my mom, we were searching online, for this DPD deficiency, what causes it, what can we do about it, how can we get her better, and came across a website called Know the Risks of 5FU Chemotherapy. This website was started by a man whose wife died in 2012 with an eerily similar story to my mom. And so contacted him, as other people have, and we started having regular Zoom calls and decided that we would go to the ASCO Quality Care Symposium. And from that, just talking to oncologists, we decided that we needed to formally become a nonprofit so people would take us seriously, and we would have a stronger platform to connect and to go to conferences, which is how I met you, Banaz. And we don't want others to go through the suffering that our family members have gone through. And so it's important to be aware of this. 1,300 Americans die every year per the U.S. National Library of Medicine from 5FU toxicity. This is like 6 jumbo jets. I don't understand as a lay person how in the United States we allow this to happen. In January 2023, there was an article in the Journal of Clinical Oncology that said 9% of the U.S. population is at risk if they're given the fluoropyrimidine chemotherapy without being tested first.
Yeah, and it leaves us to wonder why clinicians don't know about it, or don't actually, even if they know about it, they don't take it seriously to recommend, here's a test, let's consider it, and this is why, and to give the option to the patient to decide if that's something they want to do or not. I don't know if it's a cost issue. I don't know if it's insurance covers it or not, and depending on which insurance, but I really don't. Do you know, outside of obviously bringing more awareness, and it's not a high percentage, but it's still a lot considering, and why don't clinicians more, especially in the oncology, know about this test to even bring it forward to their patients?
I think maybe they haven't had a patient who had a significantly bad, or maybe didn't die. If you see a patient who does suffer with it, I think it makes you more likely to want to test. But one of the oncologists we know is, when you're starting out, I think you don't want to be an outlier as an oncologist and want to have this test. But some of the more seasoned or respected oncologists, you'd think, and I would think as a layperson, that they would want to require testing. And that's what we're seeing happening, is oncologists who have had patients pass this way, or are working with somebody they've seen the reaction to 5FU or capecitabine, and then they're seeing the amount of studies that are being published just in the last, I would say, 12 to 14 months, with saying, cancer centers are nudging oncologists toward DPYD testing. And there's been a lot of studies on the assessment of clinical utility and about putting patient safety first. So I think we are seeing a lot of momentum, and things are going to change, but it's still, we still can't give up. We still need to continue. Our president of our nonprofit has petitioned the FDA, with some help of some others, to change the labeling and to recommend testing, and written letters to the NCCN and ASCO about changing the standards of care. And we're seeing some agreement, and as part of the FDA's Project Renewal, which is where they're updating the labeling of older approved chemotherapy. Just in December 14th, 2022, they updated the labeling for Xeloda, or they're starting the process of updating it and recommending that oncologists speak to their patients about DPD deficiency. So this is a huge change. If oncologists are now going to be reading the labeling and seeing, oh, I should be talking to my patients about DPD deficiency, I think there will be more people that are going to say, well, yeah, I want to be tested, especially when you say like anywhere between 3 and 9% of the population has a DPD deficiency. I'm not going to be prescribing this to somebody or to my family member. So why would I prescribe it to anybody else without getting a test?
Yeah. Oh, I'm glad there's that momentum going. I wonder if there's a language that can be used instead of recommend, but required. I wonder, how do we get to that point of required testing? How do they determine if a patient comes in and it's a recommended, how do they determine that patient will be the one that they would test? Like, yeah, so, it just, to me, makes more sense that's a required testing because you don't know.
Yeah, especially when you think about the patients that live closer to some of the larger cancer centers. Those are the ones that are going to be getting the testing first if it's just recommended. If it's required, then a patient, whether they're in a rural community or living next to one of the comprehensive cancer centers, it will become an inequitable treatment, right? If it's only recommended.
Right. And then also, in addition, is there a language added if you see these symptoms, stop it and, get the antidote? Like, I wonder if that language is in there.
Well, very interesting that you mentioned that, because if you Google VistaGuard and go and watch a video on their website, VistaGuard, I think, has not proven to be the antidote that they thought, because, for instance, in my mom's situation, almost the damage had already been done because she was completely deficient. That wow. VistaGuard, I don't know what VistaGuard would have done if it would have reversed it. And in some situations when they administer it, most patients at the time are on a feeding tube, and VistaGuard, it's hard you want to break it up and give it to people with applesauce. So I think it is problematic when you're trying to do that through a feeding tube.
I gotcha. That makes sense.
Yeah. It's we're seeing a lot of good momentum, and I think there are some great reasons for this. It aligns with the president's cancer moonshot of the right treatment for the right patient. And we are seeing some providers that are doing testing. For instance, Norris Cotton Center, University of Colorado, University of Michigan, Dana-Farber, University of California, San Francisco. So with the more and more that are doing testing, and then that becomes the standard of care, what other people are doing, even if NCCN hasn't changed their guidelines. We will continue to petition the NCCN and ASCO, asking them to recommend or require treatment. It's too important. It's like pharmacogenomics, as you know, as a pharmacist, it's a quality improvement strategy, right? Why should patients not get the right dose for the right person at the right
start time? Exactly.
Yeah.
That is a challenge.
And just like every cancer is not the same, every person is not the same, and we all metabolize drugs differently. And this is, for me, in the last 9 years, I've learned so much, and I continue to talk to other people, but until it's more widely known and out there, it's really hard. We trust our doctors. We go to our doctors and they prescribe something, and it might not be the right medicine for you. And it could be something as simple as, Prilosec versus Nexium. Those are medicines that treat antacids, right? Or they're antacids, but they work differently. So one might not work for somebody, but like Prilosec might not work for somebody, but Nexium might. And that was like my situation just in the last couple of years. The other thing that we're trying to get people to be more aware or to know about DPD deficiency and pharmacogenomics is meeting with cancer centers and oncologists and precision medicine conferences and just sharing the patient perspective, because we're always hearing from oncologists or hospital administrators. It's very important to see the patient experience and hear what the patient reported outcomes are. It's 1,300 deaths a year. That's a lot of people
that don't have to die.
Yeah.
Yeah.
The other thing that I've been working on is I'm trying to get two large U.S. Well, actually, they're international laboratories to change their DPYD panel to increase the number of variants on it. The lab that tested my mom only tested for the most common variant, and this was her last vial of blood we tested after she had already passed away. And that lab only tests for the star 2A variant, and I am the star 13. And so I inherited DPD deficiency from my mom, but yet these two large labs, if I was tested by them, they would say I was not DPD deficient. So it's important also that these laboratories follow CPIC guidelines. I was fortunate to get my test done at my local provider in Seattle, and they sent my blood sample to the Mayo Clinic, who tests for 8 variants. And I also did a direct-to-consumer test and found out how I metabolized some other drugs, and that confirmed my DPYD variant of star 13. So I was very fortunate that the direct-to-consumer test that I use tests for 3 variants. The lab are important too.
Yeah, so I was going to say you've answered 2 of my questions already. I was going to ask you what else, outside of really awesome things you're doing higher level to get this testing done, or at least advocate for it. At the kind of I don't want to say lower level, but in the community, what else are you doing to get this message across, which you just answered through the hospitals and things like that? But you're very knowledgeable in this space, just outside of knowing the genetics of it, but also understanding not every lab report's the same and what that means, having different variants. So a lot of people probably listening on the call may not know. So it's kind of amazing how you've taken so much time to learn this genetics language, I call it, because it's not very easy. So I appreciate that. I know it's probably taken a long time to get here. But
I wish I had known more in 2014. I feel like we might have had a little more luck talking with the hospital and the cancer clinic where my mom was treated, to have them start testing all their patients. And all of the members of AUDT is what we call the nonprofit. We are all working with cancer centers in our local cities, as well as trying to talk with others on LinkedIn and find other oncologists and pharmacists who have a passion for precision medicine and pharmacogenomics as the standard of care.
Yep. Yeah. What are some of the resources out there for, caretakers, maybe those patients or providers, if they wanted to learn more? You meet with them, they're like, oh, this is interesting. I'd never heard of it. I want to learn more. Where else can I go? So to learn more, there's always the question I get, especially from providers.
Our website is test4dpd.org, and it's test, like the word, and then the number 4, dpd.org. So TEST4dpd.org. On there, you can read about it. You can see links to a lot of studies. You can see cancer centers that are testing. And there is also a page on there with how to talk to your oncologist. Sometimes you might get a situation where you talk to your doctor about this, but for some reason and I'm only a layperson, some people
You're
can't.
more than a layperson, but
some people can't wait for testing. They need to start their treatment right away based on how aggressive their cancer is. And one of the amazing things now about DPYD testing is there are labs you can get your lab results back very quickly. Like mine came back in 5 days, I think, depending on where you are. Mayo Clinic turns it around, I think in under 14 days is what they say. Mine came back in 5 days. One of the doctors on our medical advisory board, he does a DPYD panel at his intake appointment. So when he's setting up for other scans, he also does this DPYD testing so that he can get them all back. And sometimes probably the DPYD panel comes back before some of the PET scans or MRIs. And I think a lot of oncologists don't want to, or maybe not advocating for pretreatment testing because fluoropyrimidine chemotherapy is a really great treatment for solid tumors for so many people.
Mm-hmm.
But it's harmful and even fatal for others. So I think that we don't want to scare people, but yet it's, knowledge is power. If you know how your body is going to react to something, either, based on CPIC guidelines, you can reduce the dose, or if you're completely deficient, then you need to find a different chemotherapy.
Yeah, that's right. And one of the questions that I've gotten this past week was, how do I have this conversation with my doctor, which has no idea about this and doesn't believe me? And like I say, no, I want this test done, for example. It's not this specific gene, for example, or oncology, but when it comes to they know, like you, a little more about the genes, the genetics and things like that, and they want to have this conversation, but their provider doesn't have the knowledge. What does that conversation look like? What do you recommend the patient, how does the patient approach a provider with that conversation?
Well, yeah, like I said, on our website, there are some pointers on how to talk to your oncologist. And I think printing out some of the scientific studies. And it seems when you come in as an informed patient and ask your provider with scientific studies printed, which they can get from our website, I feel like a provider is going to get you the testing and also be thankful that they are made aware about these problems. I don't think 5-FU toxicity was talked about or was part of a lot of curriculum for oncologists, even pharmacists, right? Because now now you can go back as a pharmacist and get a PGX certification or take more classes. So it's exciting for me to see that pharmacy schools are also teaching about this more and more. And DPD deficiency is rare, but if we know that it can happen, to me, it's a no-brainer, right? Let's test. It's $200 test versus my mom was in intensive care with 4 or 5 specialists and medicine, so many medicines for 2 weeks.
Yeah,
the cost comparison right there just seems like we should be testing.
Yeah, we had Christina back. We had Christina a while back who also talked about her mom, and kind of very similar story, which is why you two really had to be connected when I met you. And I really always want to continue this awareness and bring it onto the podcast or a network. how can we, I want to say Pharmacy Podcast Network, but specifically PGX for Pharmacists, because it's not just pharmacists listening to the podcast, it's a lot more diverse group of people listening to this podcast. So how can we help increase this awareness and testing in the podcast?
Oh, I think just
what would you love to happen? I guess I should say.
What would I love to happen? I would love to see the NCCN and ASCO and the FDA require treatment before DPD or before fluoropyrimidine treatment, just like it's happening in many parts of Europe. That would save so many lives.
I wonder why they're more forward over there than here.
Yeah, that's a good.
Yeah,
that's a good question. I think it's so important that we, as patients, understand the risks and share what we know with others, and that oncologists will hopefully start requesting DPYD testing prior to fluoropyrimidine treatment. Mm-hmm. Even now they don't have to wait until it's the standard of care. Also, I think what I've learned is oncologists are so busy, so hospital administrators play a part in this too, right? They need to make it easy for an oncologist when they're seeing a patient on their system, in whatever technical or electronic health record, is to request a DPYD test, right? Make it easy. Right. And pharmacists doing like you're doing, educating others about pharmacogenomics and how we all metabolize drugs differently. And thankfully, insurance providers the payers, insurance companies are changing and starting to cover these costs. My DPYD panel was paid 100% by my insurance. I was surprised.
Oh, well, that's so good to know, because that was my next question, to see if it was, because I know you did yours. So it's good to know. I wonder if it depends on where you had yours done, or whether just that test is covered regardless of which lab you had selected. I'm not saying you have the answer, but those are things that, to look into. So I don't know if some patients may need to call their insurance and get a pre-authorization on that, or maybe the hospital will do that work for them. I'm really not sure, but these are all the questions and things that the hospital or the provider can really provide to make it easier for this thing to be done, and then get the results, like you said, sooner than later, right?
Right. Yeah, I think some hospitals that are doing testing are bringing testing in-house so that they can save a little bit of money, right? Some other hospitals that right now, if they don't have the lab capability, they can send it out. But it is important for patients to know if their insurance will cover it, and have that conversation with their oncologist and the hospital that they're being treated at.
Yeah. Well, I'm grateful for you to come on and share your story. I know you probably had many people before me that wanted you to share their story for awareness and education purpose. So reliving that, I know it's not easy, but we appreciate it to bring more awareness for everyone listening. Is there anything you want the audience to take? That you've already provided a lot of information, but is there one last thing you wanted to let the audience know before I let you go?
Oh, well, we are going to be our nonprofit at the American Society of Clinical Oncologists annual meeting in June. We're very excited to be able to, get the information out there and into the hands of more oncologists from a face-to-face conversation, and, not ignoring the human cost of DPD deficiency any longer. We know it. We have the science to test for it. And so now it's time to act on this, right? This is a patient safety matter. And pharmacogenomics is a quality improvement strategy for hospitals. So I hope that hospitals will start seeing it as that a quality improvement matter that they can make part of their clinical implementation plan so that they can reduce suffering and save lives.
Well, thank you for that. And I appreciate everything you do every single day for everyone you're touching lives. I appreciate that. We appreciate that. Thank you, Karen.
Well, thank you, Banaz, for it was wonderful to meet you. And also, I think the connections, like you connected me with Christina and heard her mom's story with capecitabine. And it's very sad to hear of the suffering that others have gone through. And that's why AUDT is so passionate about what we're doing, because we don't want anybody else to lose a loved one and have them go through the suffering that our loved ones did.
Definitely. And thank you, Karen. And thank you, everyone, for listening to PGX for Pharmacists podcast on Pharmacy Podcast Network. There's no other place to go for all your PGX needs. We do a lot of PGXing on here, the science, the business, the reimbursement piece of PGX. We want to hear from you, so let us know what you're thinking by leaving us a review, or let us know what you want to hear more of on our next episode.
Thanks for your interest in PGX and for spending some time with us. Please share this podcast and leave us a review on Apple Podcasts or Spotify. For all of our episodes, please visit pgx4rx.com. That's pgx4rx.com.